I'm not very formal when I do this, so please, if you have questions and you want to stop and talk about stuff in the middle of this, just stop me, okay?
Your attention, please. Fire alarm system.
Oh, good, the fire alarm system. That's always nice in the middle of this, so. So when Deanne asked me to do this, she asked me to, we talked about a bunch of different things, but what we talked about was maybe going over some of the lab stuff that you guys see. And then I also, I'm going to move this out a little bit so that I can get out a little more easily than I did yesterday. Then I also talked about, to my colleagues, am I going to drive you crazy moving around?
You might.
Probably, okay, I'll try to stay better.
You just need to hear it.
I also talked to my colleagues, I am a nurse practitioner also, and I talked to my colleagues in primary care about, because we all, I think what you need to know about this is that we all look at this as one big kind of happy family who works together with the patient at the center to try to keep the patient at home functioning in the community. And the goal is to keep them out of the hospital. Not that we don't think you all do a wonderful job, but as you all know, the big push is not to have readmissions. Okay? So what can we all do to not have readmissions, especially those readmissions within 30 days at hospitalization? And so I talked to a bunch of my colleagues about what is it that we could all do to not have readmissions. And so I'm going to, kind of integrate some of that stuff along the way too. Okay? Because I think the biggest thing that we need to all realize is that we are a team. And you are a colleague in the care of these patients. And you are probably the most important colleague in the care of these patients because you are the one who is there with them and seeing them and caring for them as they are probably in the most critical portion of their care because they come out and now they are, oh my God, what happened? What do I do? How do I manage this? And so you're the one who's there trying to help them make sense of this, and the one who's communicating with everybody. So I'm sure you feel this. You get it from the patients, from the families, and especially in the summer from the newer people on the team. Is that a nice way to put that?
Yeah.
Yes, okay. From the newer people on the team. And trying to manage all of that. So, and as a nurse myself, I think you're the most important people on the team. So, anything that we could do to help you to do that is, I think, very important. So stop me if there's anything that you want to talk about with this. So what I'm going to do first is go through some of the post-PCI labs that we think are critical and that we can talk about a little bit further. And then we're going to do a couple case studies and then talk about post-cath stuff and do a couple more case studies. Okay? All right. I like my cartoons, so this is the first one here. All right. So one of the things is that despite advances in therapy, there are actually a lot of people still having MIs, and MI remains a huge cause of death. So why do you think that happens? Why are we still having a lot of problems with MIs in the United States? And it is a lot in the United States.
Normal risk factors that people still have, like genetic.
Okay, so people have a lot of risk factors genetically.
Diet.
The diet is awful.
Live longer.
People live longer, so we have a lot more elderly patients coming in with them. Think of the ones that you're seeing. What else? The comorbidities, absolutely, the comorbidities. So what are you seeing as comorbidities?
Diabetic.
Lots of diabetics. Okay, so what do you know about the diabetics and the comorbidities? The hypertension, yeah. What else happens with diabetics?
Compliance.
The blood sugar control, they're not so very good at that a lot of times.
Compliance.
Compliance is a problem. And why is compliance a problem with patients? Aside from the problem that they're patients and compliance is a problem. What else goes into that?
Financial
Lifestyle.
issues.
Financial issues. Yep.
Access to their medications, just getting to pick them up and.
Just even access to medications. But the financial issue is a real issue. And we're going to talk about that a little bit too. And that's another area where we can impact. Okay. Let's not forget too about tobacco use. Okay? And I'm sure that you see this, patients coming in who are still smoking. I worked for 10 years in pulmonary as a nurse practitioner. They have never yet found a good thing about smoking cigarettes, but we still have patients that are smoking cigarettes. And I remember from being up on the floor, I would still catch patients trying to smoke cigarettes in bathrooms and things like that. You know, with the oxygen still running, you know, be afraid I was going to be blown up. And you probably, I'm sure, still find people trying to do that. We do have an absolutely excellent stop smoking program here. And one of the things as an intervention that you can do, and any nurse can do this, is refer a patient to the smoking cessation program. And any patient who is a smoker should probably be referred. Most patients or most individuals who are smokers will attempt to quit smoking 7 times before they're successful. Okay? So if you have a patient who says to you while you're counseling them, "I'm sorry, I've tried twice and I'm just not able to quit," your response to them is, "Great, you only have 5 more times." And then you're going to be successful. Because most people try 7 times before they're successful. So aren't you great? You've got 2 of them out of the way. And we're going to give you some help for the rest of them. Okay? And maybe you won't go all 7 times. Maybe you'll only go 3 times. So isn't that good for you? Aren't you? You see, you've gotten some of them done. So that's good for you. So perfect. Great. You've shown that you can do it already. So nobody's Superman. Nobody gets out of here without a little help. So you spin it positively for them. Because patients will tell you, "I'm sorry, I can't do it. I've already tried it once." You say, nobody succeeds on the first time. Really, they don't. So that's what you say to them about that. Okay. We diagnose the MIs based on clinical history, EKG, and blood tests, especially the troponins, and we'll talk about those. And outcome is determined by infarct size and location and timely intervention. Okay. And I just read that we got a designation here. It was in Vital Signs this week as a PCI place, right? So congratulations to everyone because you're a part of that. And we will talk about intervention time and things like that. Okay, so post-STEMI priorities. Okay, so this is some of the things that you will be involved in when you have them. Okay, we have to talk to them about compliance and taking medication exercise prescription, oftentimes they're referred to some type of a therapy or a cardiac rehab. Okay. Smoking cessation should begin in the early phases of hospitalization and then following up from there. Community support groups, if it's appropriate, and this may include both for the patient and the family, depending on the age of the patient. And don't just assume because the patient is young that they don't need it. Okay, oftentimes the young patient will need it. Okay. And then post-discharge pharmacotherapy and lifestyle management. Okay. Obesity is a real predictor of patients having a secondary MI, so diet management and referral to diet therapy is very important. Okay. Have you guys heard about this classification, Kipling classification? Okay. I put it in because you may hear about it or you may read it in charts. And it's one of the ways that they classify patients and how they do and how they manage and their prediction of how they will recover. Okay. So if they have an MI, in order to stratify their predicted death, this is one of the predictors. Okay? So if they don't have any evidence of heart failure, they predict that they could die, 60% will die within 30 days. Still pretty high, right? I was surprised at this. Okay, and that's because they have their chance of reinfarct is still reasonably high. Okay, because people go out and do stupid things. All the way up to class 4, and that is if they have cardiogenic shock, hypoperfusion, their mortality can be all the way up to 67%. Okay? Okay. So the critical period of monitoring patients is the days immediately following. And the ways that we monitor them is through their labs, through their ability to ambulate post-intervention, through the level of their pain control, their ability to go without smoking, their ability to adjust to a new medication regimen, and that is both their ability to take the medication without having terrible side effects and their ability to take it without their labs going crazy, and their ability to tolerate the new medications, because some people have a lot of trouble tolerating new medications, and then starting education and actually being able to understand the education, because we have a lot of different types of people and a lot of different types of educational level. And when somebody has had a major health problem, their ability to absorb information is more limited. Okay. Okay, you're the one there to be able to evaluate the progress and to be able to evaluate the responses. So you're the critical person in this process. Okay. Let me just go back to this for 1 second. Ambulation. One of the things that the outpatient people said to me was if they had one thing that they could ask is if you assessed that a patient was dicey on ambulation, that a full assessment risk was made in hospital and that referrals would be made before a patient left. Because one of the things that we are finding as a contributor to rehospitalization is falls, especially falls on the newer anticoagulants. Because of course there are no antidotes for the newer anticoagulants. And the patients are coming out on these new anticoagulants because of course they're much easier for the patient to take. But I saw somebody in the practice just 2 weeks ago, lovely little old lady, post-MI, had had a PCI, and she had tripped over a rug in her house and fell down, thankfully did not break a hip, but she had a hematoma on her knee that swelled it up so badly that she was then readmitted. Now, it was not an MI readmission, but it still counted against the 30-day readmission. If you put down that you want to have an evaluation of her environment, that will be done for free. Okay, a fall risk for her, and then the VNA will go in and look at her environment. So that can be done. So that's one way that we can work together to make sure these patients are safe. And then the little darling would have not gone back in the hospital. And we all wouldn't be getting little messages in our email. Okay, I'm going to talk about some labs for a little bit now. Okay, troponins. Okay. We don't normally see troponins. Okay. It's only released when you get necrosis in the myocardium. We have troponin T, which is found in the blood, and it's related to contraction of the heart muscle. And it's very indicative of heart damage and risk. Okay. It increases in 3 to 12 hours from the onset of chest pain. Okay, so the patient starts to feel the chest pain, and then 3 to 12 hours it starts to go up. You get a peak in 10 to 24 hours, and it remains elevated for a fair amount of time. Okay, you get it for 1 to 2 weeks. We have a troponin I and a troponin T. Okay? If they have marked elevations, in other words, 5 times normal, it indicates worsened outcomes for the patients. So this is one of the reasons why they do serial troponins, because they're looking to see if they're getting those huge spikes in the troponins. So that's why they're doing serial troponins. They're looking to see what's the pattern of the troponins. Because it can also tell you, is this an old infarct? Is this a new infarct? Did this happen 2 weeks ago? Did this happen, is this an evolving infarct? Okay. Is this a big old bad heart attack? Is this something that's happened ages ago? Okay. We used to look a lot at creatinine kinase. Okay. This has fallen out of favor a little bit. The reason being is creatinine kinase is found in a number of things. Okay, it's found in skeletal muscle, it's found in brain, and it's found in heart. Now we have 3 different kinds. We have CKMM in the muscle, CKBB in the brain, and CKMB in the heart. But what they found is that the sensitivity and specificity aren't as high as other lab tests. So you still may see it drawn, but it's not paid attention to as much as other values. Okay. They will look at it, you may still see it, but it's not the one that they care for as much as a diagnostic test. Okay. And this is just an example of what, this is the CKMB, this is the troponin in a large MI, troponin in a small MI. It's a very standard graph, just what it looks like. Okay. Myoglobin is a protein. It's found in both cardiac and skeletal muscles. Okay, so you may have seen this drawn. They're sensitive but not specific. And when I say sensitive but not specific, you're going to see them rise. But they also rise because they're in skeletal and cardiac muscle. So because they're in both skeletal and cardiac muscle, we can't say that it's specific to the cardiac injury. Okay? So they look at it in context of the big picture, but it's not specific to the cardiac muscle. Okay. LDH. Okay. LDH rises above the reference range within 24 hours of an MI, reaches a peak within 3 to 6 days, and returns baseline in 8 to 12 days. Okay? This one you have to look at in context of all the other things that are going on with the patient. Okay? So if you have a patient with liver and kidney disease, or pernicious anemia, or who has cancer, or who's had a pulmonary embolism, they may also have high LDH. But what you're looking at is the pattern of that elevation. Okay? So remember, you're looking to see, these would have to be serial draws for the LDH. Okay? These are the normal values, and you're looking at LDH1 and LDH2. Okay. Normally, LDH1 is less than LDH2. Okay. In an MI, they have a flipped appearance. In other words, LDH2 is less than LDH1, and that is very significant. Okay, so the next time you get a patient, take a look at that. That's very significant. It happens in the first 24 hours and it persists for the first 48 hours. Very suggestive of an MI. Okay. Now, Dan asked me about this, the BNP. She goes, everybody keeps looking at this BNP marker. And we don't really know why this is going on. And I said, geez, I don't know. I never looked at this when I was doing this stuff. So I did a little research on this, and it's a very interesting thing. Okay? It really is an indication of left ventricular function. Okay? It rises over the first 24 hours and then tends to stabilize. Okay? It's an indication of remodeling process of the left ventricle. Okay? And it really indicates the remodeling of that left ventricle. But if you have a very high level of BNP, it's a very powerful marker of left systolic dysfunction and a poor prognosis after an MI. Now, I will tell you that this has not been accepted as evidence-based practice yet. So you're going to see people using this, and I gave you in your packet of things the August 215 circulation article that says that, yes, this is very interesting, and you're going to see a lot of people using this and evaluating this, but this is not standard practice yet. Okay, so read that article. Very interesting. There are a lot of studies that are suggesting it, and that it might be the reason why they like it, because how else would you evaluate left ventricular dysfunction? How do we look at the left ventricle through testing? An echocardiogram? Yeah. Or they'd have to go in and do a cath and do a ventriculogram. Okay, much more invasive and a lot more money, right? So a BNP is just a lab test. So everybody likes that. It's a lot easier, right? This would be a big thing if the research really brings this out and we find that this really works. That would be great, wouldn't it? But it isn't exactly accepted as in the evidence-based guidelines yet. So, yes, wonderful. Yes, we like it. But I wouldn't put all my money on it right now. Okay? I think it's very interesting. I think there's a lot of research that supports it, but it isn't totally accepted yet by everyone. Okay? So keep your eye on it. Read the article. Keep looking at your patients with it and seeing if it really does predict it. I'll be interested to hear, but I'm not exactly, I won't tell you that it's evidence-based practice yet. At least that's not what the American Heart Association says. Okay, other significant tests. Okay, you'll always see a CBC drawn, all right? One of the reasons is they want to look to rule out anemias as a cause of decreased oxygen supply, and they are always going to look out to make sure the patient is not anemic before they give a thrombolytic agent. That would seem to be good practice. Okay, because we don't want to give them a thrombolytic agent and find out that they're terribly anemic. At least we hope, okay? White blood cell count is going to be elevated post-MI, okay? Generally speaking, you're going to have, anytime you have an insult to the body, you're going to get some kind of a spike in the white blood cell count. It should be moderately elevated, not hugely elevated, okay? If you get a huge elevation, okay, what does it mean when I say a shift to the left? You hear that all the time. Anybody know? No? It means that there's lots of immature white blood cells. Okay, that's an old term. So lots of new white blood cells. Okay, worked the entire time I was here, right? Because you always hear that, shift to the left. Shift to the right then means lots of old white blood cells. Okay, so the person is not producing new white blood cells. Okay. Okay. But let me just go back to this for 1 second. If you have a huge increase in the white blood cells, what would you be concerned about? Infection. Okay. Let's go a little bit past that then. If you have, oh, new baby. If you see a huge increase in the white blood cells, you're getting this patient back PCI. Okay? So done intervention.
Thrombus?
Okay, thrombus. And what else might we be concerned about? Think the most usual first. You said infection. What are the sources of infection that we'd be concerned about? Could be cardiac. Yep, could be cardiac. They could have introduced something. Okay, so you're going with your nurse practitioner brain, where you start with death first. That's the nurse practitioner brain. You start with death and then you go backwards. Think very common. What's the most common cause of an infection after an intervention?
Insertion site.
Insertion site. Okay, so the first thing you do is look at the insertion site. And what are other common causes of infection?
Pneumonia?
Respiratory. Yep. Urine. Okay. So you got to think straight down the line. Okay, you get the lab values up. You see, rather than a moderate increase in the white blood cells, you see, which is expected, because they've had an insult to their heart, you see a huge spike in the white blood cells. So you're going to immediately look at the common sites, the common ways that somebody would have a huge spike. So we're going to look at insertion, we're going to evaluate respiratory, and how do we evaluate respiratory? No, you're getting way too fancy. You're just going to listen first. Okay? You're going to evaluate urine, right? You're going to do what for heart? Listen. Maybe hook them up to an EKG. Okay? And then we have information to convey. Okay, we have a huge spike in the white blood cells. This is what we have. We're going to convey this information. So you never just say there's a huge spike in white blood cells. There's a huge spike in white blood cells. We've done this, 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 and this. What do we want to do next? Right? Because you're part of the team and you direct the care. Okay. SED rate. Okay? I will tell you, in my opinion, this is the most worthless test in the world. Because everybody who has had any kind of an insult to their body is going to have an elevated SED rate. You will still see everybody ordering a SED rate. Okay? It's always going to be elevated after somebody's had an insult. I don't know why we still do it, but we still do it. Okay. Platelet count. This is a critical test. Okay? The platelet count always has to be drawn. Oftentimes they will draw it pre-intervention and then draw it serially post-intervention. What they're concerned about is heparin-induced thrombocytopenia. Okay, and it's always necessary when we're using these newer agents also. Okay, the patient has to have a reasonably adequate platelet count or they cannot remodel. Okay, the critical issues for a patient after coming out and having an intervention, so coming to your unit, will be that they need to get up and ambulate, and it's usually 4 to 6 hours after an intervention. They will have, in general, orders to have certain medications. They will be on aspirin, they will be on a beta blocker, often, and an ACE inhibitor. almost always on a statin. I would love to have bought stock in statins about 2 years ago, because now the research has said, in the evidence-based practice, is that if you have one cardiac risk factor and you are, I think, over age 45, they put you on a statin, because the research has shown that it improves your profile. So certainly one cardiac risk factor is having had an MI. And I'm sure most of them have another cardiac risk factor. So most of them will be on a statin unless there's, the only non-indication is if they've had an allergy to it, really. Right. They will be on some kind of anticoagulation. Okay. You will be screening them for complications. Are they on telemetry or no? Come off? Go on? Okay. Sometimes on, sometimes off? Yes? Okay. Okay. Education and counseling for smoking, dietary, risk factor reductions. Most of that they won't hear. Okay. One of the critical things with that then is they often need not only oral education, but written education. And if you don't have written education materials, that may be something you want to work towards, is having written education materials for these patients about at least the big areas. Okay, and you can see that I have down here echo for left ventricular function, thrombus, and BMP instead, because now they're probably moving more towards doing a BMP instead, unless they're really concerned about that. Okay, so now I'm going to stop for a minute, and we're going to do a case study. Okay? So we have case study number 1. Let's see. On myself. So the way I want to do this is just have you read through the first section first. Okay? I think you got the answers to them too, but
Sorry.
but we'll have a discussion about it, okay? So, just read through the first section first. We have patient A. Okay, so the first section, we have a guy who is 54 years old, and he comes to the physician's office with complaints of chest pain. He's chest pain free when he comes in. His 12 lead shows no changes from previous EKGs. Vital signs are stable and in the normal range. Blood pressure is 135/78, heart rate 68, respirations are 16 and unlabored. He's afebrile. He gets questioned about his chest pain episodes, and he reports until a week ago he's been having his usual, in quotes, occasional chest pains when he, quote, works too long or too hard in the yard. However, over the last week, his chest pain attacks have been lasting longer and requiring more sublingual nitroglycerin for relief. The previous night, he had experienced a prolonged episode of chest pain at rest and decided to seek medical attention. His history includes CABG surgery 5 years previously, a drug-eluting stent to open a blockage in one of his saphenous vein grafts from his prior CABG 2 years ago. He takes medications for dyslipidemia, with his most recent lab tests showing his LDL was borderline high at 135. Stopped smoking following the stent placement 2 years previously. He's 30 pounds overweight. When he mentioned the need for weight loss, the patient's usual reply was, "It's either the weight or the smoking. I can't manage both." Given his previously known coronary artery disease and previous history of CABG and PCI with stents, his continued risk factors, he instructed the physician instructed patient A to go to the ED of the local hospital. The patient declined transport by EMS and insisted on driving himself. Okay, what do you think about this? Number one, does he have stable or unstable angina? What do you think? Unstable. Does anybody say stable?
It's at rest, so it's unstable.
Okay, and the reason why it's unstable is because he has chest pain at rest. Any other clue to being unstable? Requiring more nitroglycerin. So both of those things, by American Heart Association standards, lead to the fact that it's unstable angina. Anything that is requiring more therapy and is at rest, by standards, lead to unstable angina. Okay. He drove himself to the hospital. Anybody have a problem with this? Everybody has a problem with this, including all the people who were on the road that day. Okay. This absolutely goes against American Heart Association standards. Okay. The reason being is he could take out, have chest pain while driving, have a big old MI, and take out a family of 4 and a school bus. Okay. This should never be allowed to happen. Okay. It really shouldn't. Anybody who's having increasing things. Now, I do understand that at the time he was there, he wasn't having any issues. And this is probably one of the most difficult things in primary care, to get somebody to say, okay, look, I know you're not having issues right now. However, the issue is you could. And do you want, when your spouse is with you or while you're in the car, for it to occur? So, okay, go on to the next one there. Okay, in the emergency department, he developed chest pain. It was 10 out of 10, located on the left side of his chest, substernal region. He was slightly diaphoretic with a blood pressure of 170/90, heart rate of 110, and diaphoretic. Chest pain protocol was activated. He received aspirin and instructions to chew it before swallowing. He was given sublingual nitroglycerin and oxygen at 2 liters. 12-lead EKG was performed, blood work and CK&B and troponin T were drawn. 12-lead EKG showed non-specific ST segment and T wave changes. 5 minutes after 1 sublingual nitroglycerin, the patient reported his chest pain was 10 out of 10. Blood pressure was 140/88. Second sublingual nitroglycerin was given. 5 minutes later, he reported his pain was 8 out of 10. His blood pressure remained at 140/88. Third sublingual nitroglycerin was given a minute later. Patient reported his pain was 5 out of 10. His blood pressure was measured at 132/80, and the physician ordered 2 milligrams of morphine IV. Any questions or concerns about this treatment of the patient?
Oh, we don't want to chew the nitro, right? Does it matter? You chew it?
Chew the
Oh.
aspirin.
Chew the aspirin.
I was-
No, but you wouldn't want to chew the nitro. You're right, yeah. No, wouldn't want to chew the nitro.
Got the morphine, oxygen, nitro, and aspirin.
He did get morphine, nitro, oxygen, aspirin. How about the timing and stuff? Would you have changed anything?
Shouldn't the morphine come earlier
Yes, morphine should have come.
in the first?
I think morphine should have, well, he got everything. They could have given him the morphine a little bit earlier, because how does morphine act in this protocol?
A vasodilator.
It's a vasodilator, sure. And he was having a lot of chest pain, wasn't he? He was 10 out of 10, 10 out of 10, 8 out of 10. They could have given him the morphine earlier in this scenario, because remember, the clock starts ticking when?
When the chest
And then
burst
it
starts.
Yeah. And when he hits the door, your clock starts ticking to intervention. Right? So now we've had him in the ED for this period of time, and we know it's been at least, with this, at least 15 minutes. Right? So we're on a ticking clock with this fella. And what's the standard protocol for intervention now? 90 minutes. And we've chewed up 15 of them here. Not so good. Huh? Okay. So that's a concern with this. The clock is ticking, and they could have given him a little morphine earlier. Okay, let's go on now. You like that morphine? Okay, after receiving the morphine, he was chest pain free. Blood pressure and heart rate returned to the quote usual level. His initial biomarkers returned negative for cardiac damage. Are you surprised at that? It's been 15 minutes. You think they should be positive or negative?
We had the chest pain at rest the night before.
Mm-hmm.
Does that cause them to increase then?
It might if he had actually had the heart attack then, if he'd had an MI then, but maybe he didn't have the MI then.
3 to 12 hours.
And if you had one in the ED, it'd be too early as well.
If he had one in the ED, it'd be too early as well. So maybe or maybe not. So maybe just too early to get positive biomarkers. Okay. Physician made the decision to admit him to telemetry step down for further observation and monitoring. Admitting diagnosis was possible ACS. Admitting orders were for serial biomarkers, continuous ECG monitoring, and immediate 12 lead with chest pain. Second set showed elevated CKMB level. Repeat ECG indicated no evidence of ischemia or infarct. Third set of cardiac biomarkers, approximately 8 hours later, showed that the CKMB levels increased and the troponin was positive for myocardial damage. Another ECG taken immediately after the return of laboratory work did not show any evidence of ischemia. However, minutes later, patient A developed chest pain, ST segment depression in the inferior leads and was noted on continuous ECG monitors. Okay, what do these labs indicate and what's most troubling? Okay, the ST depression is most troubling to you?
He hasn't been to the cath lab yet.
Well, now we are
It's over 8
now,
hours later.
we're now at 8 hours later. 8 hours and 15 minutes later at least. Okay, and he has ST segment depression. And what else?
And chest pain.
And chest pain. Okay. What about the labs? So what does that indicate to you?
Heart damage.
He's had some ischemia. He's had some heart muscle damage. He has had some heart muscle damage, and somehow we didn't pick that up. Okay. All right. The physician orders a continuous heparin infusion along with a bolus of ephedramine, followed by continuous infusion. He had been administered aspirin in the emergency department. On the floor, he received 600 milligrams of clopidogrel along with the low-dose beta blocker. He developed another episode of chest pain that was not relieved by nitroglycerin or IV morphine. As a result, he ordered a continuous nitroglycerin drip. What do you essentially want to monitor at this time? What labs? What would be critical?
Platelets.
Platelets. Yeah, absolutely platelets. Okay. What would you be concerned about with him? Hip. Yeah. Because we've now given him a number of things that might affect his ability to clot. Okay. He was taken to the cath lab for possible PCI. Cardiac cath revealed he had an area of blockage in his right coronary artery. His previous stent remained open, and the other vein grafts from the previous surgery were also patent. PCI was placed with a bare metal stent. Following the cardiac cath, he was returned to his room. Post-catheterization orders included instruction for bed rest for 4 hours, continuation of the ephedramine drip for 18 hours following the conclusion of the PCI, serial monitoring of cardiac biomarkers, and a complete blood count. Nursing care included continuous ECG monitoring, frequent vital sign checks, frequent monitors of arterial puncture site for evidence of bleeding or hematoma, assessment for signs of recurrent chest pain, left flank pain, and he was encouraged to drink fluids, and urine output was monitored and recorded. Initial blood work showed a drop in the blood count from high normal to borderline low. Second set of blood work 6 hours later showed a dramatic and significant drop in the platelet count. What intervention or communication would you do, and what are your concerns? First of all, what's your intervention at this point?
Call the doctor.
You definitely call somebody, yes.
Yeah.
Check the bleed.
You're gonna check the site.
You gotta check the site. Turn off the drip. Yeah, I would turn off the drip. I'd go right for that clamp. I I agree with you. Yeah, I would turn off the drip. You can't let stuff be running into them with a platelet count that low. Yeah, I would take that action myself, I agree with you. You can't be running an anticoagulant to somebody with low platelets. And absolutely communicate with your colleague and say, oh boy, we gotta do something here. Yep. And then check every orifice on this patient's body, not just the puncture site, but I'd be checking all the other orifices too. Making sure that there's nothing running out of any orifice on this patient's body, because we've now dropped him quite low. So I'd be looking, yep.
Other than receiving heparin, are there risk factors for the heparin-induced thrombocytopenia? I mean, genetic, or is it?
Yes, that's a very good question.
Much heparin in a lifetime, or?
No, it's not, because heparin has got actually a fairly short half-life. So once, we stop it and we reverse it, we're okay. So it doesn't stay in the system for long, and it's got to, we can reverse it. Vitamin K is a reversal. So we can do that. That's why we like heparin, it's, as opposed to the other, the newer, the NOACs or the novel oral anticoagulants, which don't have reversals.
So say I develop the HIT, am I prohibited from getting heparin?
No,
Ever again?
No,
because
no.
of that.
no, you are not.
They have do you use the free T4 score? You can actually indicate a patient's predisposal to HIT. There's a free T4 score, you can find it on like the NIH, so not usually an oncology population, but anybody who's going to be using heparin. It's called a free T4 score, and it bases it, there's 4 different T's, and we can look at it later because I can't remember off the top of my head.
Nothing to do with the thyroid.
No,
Okay.
no.
So it's like we use it a lot in oncology, but it'll give you the indication of are they at high risk, low risk, moderate risk for HIT, and then if they are at high risk, you would try to, you want to monitor more closely. You really don't have a choice in this kind of population.
Right.
But would they, for something like this, if they did end up with HIT, would you want to reverse it, or would you just monitor it?
It would depend on how low his platelets actually are. So I didn't give you a number, and I don't think I had a number in this case study, but if his platelets were very low, you might reverse it, or you might partially reverse it.
And what are they using? They don't use argatroban anymore. What do they use to reverse it?
They were using argatroban,
I don't know if they still do.
but I don't know if they're still using it here. It depends on institution.
I had a patient, not a cardiac patient, but she had a thrombus and she developed an HIT.
Yeah.
Yeah. The last,
What's critically low for this type of patient? Is it the same as critically low for an oncology patient?
critically low is critically low. It used to be a institution standard.
I don't know, 50 to 100.
50 to 100 usually is what it is. Yeah. That's generally what it's standard. Okay. And in some cases, they will do it pre-intervention, and if it's 50, they won't do the intervention. Okay. So, in this case, this patient, but you asked a question, are there people who are genetically predisposed? And yes, there are, there are people, Mediterranean types of people can be more genetically prone to HIT. So there are individuals and genetic strains of individuals that are more prone to developing HIT. But that is a genetic test.
And what percent of patients are apt to develop this?
It's a very small, well, if we over-medicate them, anyone. So that's why we do the monitoring. So anyone in this room could develop it. But genetically predisposed, I would say that less than 2%. Okay, so as a genetic group, very small. So it's not something normally that you would worry about in a patient coming in, but it is something that you would worry about for every single patient. Because of people giving too large a dose or not monitoring carefully. So that's the biggest concern with it. That anybody who's on these medications have got to be carefully monitored. Okay. And the last question is, what are priorities for discharge? And what might you offer this patient? And go back to the beginning and look at that. What would you be concerned about with this guy?
Coming to the hospital earlier.
Yeah, he's not, doesn't seem to be the most compliant guy in the world.
Weight loss.
Weight loss, yeah, weight loss.
For
Medication.
discharge.
Medication compliance, you might need a lot of education with that. Yeah, medication compliance.
Cardiac rehab, maybe?
We might want to put him in cardiac rehab because that would force him to be with a group of other people who might help him with an exercise plan and talking about things, and you're not alone in this world. This isn't a fight that you have to fight by yourself.
Is dietary involved with cardiac rehab? Or
Yes. Yep. Yep. They do a lot of group work. You could refer him to dietary. That would be a good thing to do. And he's going to need a lot of work on his medications too, because they're going to put him on a few new things. So, okay, I'm going to go through the post-cath labs and then we'll do the other studies, okay? All right. The biggest thing with catheterization stuff is that you have to remember that all of the catheterization materials are filtered through the kidneys. So someone who does not have good kidney function is going to be at risk. Okay. So we want to evaluate or make sure that this is probably going to be done before they get to you, but it's also worth monitoring after the patients. And so patients may have a catheterization, something may then be done, and then they may come to you. So you may want to, anyone who has had a cath, had an intervention, and then come to you, you're going to want to take a look at their kidney function. Okay? So, BUN, creatinine, and GFR. Okay? One of the big risks is contrast-induced nephropathy. Okay? And what happens is you get a rise in creatinine post-cath. Okay? Okay, so what the biggest issue is that they're not filtering correctly. Okay? The biggest protection for kidneys is to hydrate. Okay. The next thing is the PTT and INR. Okay. If your INR is not correct, my INR symbol is incorrect on this. Okay. You want your bleeding. I think I have my greater than and less than wrong. Okay. We want to have our bleeding risk low. Okay. We don't want the patients to bleed out, in other words. CBC, we want to, what are the hemoglobin and hematocrit? Okay, and you have to look at this in the context of the patient. Is the patient, if you have a previous hemoglobin hematocrit, that's good to look at. Okay, is the patient chronically low or high? And again, the WBC, you have to look at this in context of the patient and look to see if the patient has had this WBC before, and then if WBC spikes, what is the source of the spike? And the platelets are very important because they do go through someplace. Okay. Again, they will not do a cath if platelets are low because they need to remodel. And the last one is a chemistry. Okay. The potassium is the most important one. Okay. Especially if they do a ventriculogram, because that tends to disturb the heart potassium. Okay. And that is very critical to monitor because it tends to cause dysrhythmias. Okay. So very critical to monitor the potassium. Okay, so post-hospitalization, one of the things that the primary care guys thought was very important was that when scheduling appointments, patients usually come out and they have an appointment, they have a direction to see their primary care doctor and to see their cardiologists. And just because of scheduling, oftentimes they end up seeing the primary care person before they see the cardiologist. Well, the primary care guys don't want to mess with the cardiac medications. But the thing that the patients have the most questions about are the cardiac medications. And, why am I taking these, and should I change this, and I'm having this problem with it, and things like that. So if there's any possibility of scheduling cardiac before primary care, that would be the best way to do it. Because the patients are terribly confused, and they have a lot of questions about that. So that may be a pie-in-the-sky dream, but that would be a wonderful thing if we could do that. Okay. Again, medication education, written education would be a wonderful thing for these patients if they could get them, because they really have a lot of problems retaining information post new medications. Especially, it seems, with the what am I taking and why is it for? So I'm taking this new medication. They may know the name of the medication, but they don't know what the medication is for. And it's startling, some of them. So this one is for my hypertension, and this one is for bleeding risk for anticoagulation. They don't have any idea. They can hand you a list, but they don't know which one is for which or why I'm taking them. And you get an awful lot of, because that's the one they told me to take, which is awful, terrible thing. Even to the point with, I can't afford all of them, so I'm going to stop taking one. And sometimes the one they choose to stop taking is the anticoagulant. And you go to yourself, oh God, I wish you had decided to stop taking like the ACE inhibitor, you're still on the beta blocker, that could, if you're going to decide to stop taking one, don't stop taking the one that's going to keep the clots from forming in your heart. They need more knowledge of, and it's not just your job to do that, but we all need to work together to educate them better about which medication is for which thing. So. and fall prevention and referrals. And especially if they are going to fall, we need to get them into PT and some therapy. Okay, all right. So, we have another case study of a little old lady. Patient B, you want to get up and move around and shake for a moment? Did you do that? No? You okay? Good? Okay. Okay, so patient B is a 63-year-old woman. And she goes to the emergency department with a complaint of intermittent epigastric pain and chest discomfort. She reports that the discomfort has occurred intermittently over the previous 2 to 3 weeks. When questioned, she admits she felt more fatigued and had periods of shortness of breath and lightheadedness over the same period. At the time of presentation to the emergency department, she reported that she was experiencing no discomfort. Blood pressure was elevated at 210 over 120. Heart rate was 84. Respirations were even and easy. She did not appear to be in acute distress. An initial EKG showed no signs of acute ischemia or infarct, but did reveal pathological Q wave. The initial cardiac troponin returned indicating the level to be borderline, but not yet elevated. When patient C admitted she has had high blood pressure for, quote, a while, and that she does not always take her medication as prescribed. Okay, what are your comments about the symptoms and presentation of this patient? What do you think?
Women usually have less common symptoms.
Okay,
not
women,
necessarily chest pain.
yeah, women usually have less common symptoms of AMI, not just chest pain. So let's go through what are the women's symptoms of AMI that you might see. Say that loud.
Fatigue.
Fatigue,
Epigastric.
nausea, jaw pain. What else? Shortness of breath. Anything else you could think of? I just didn't hear what you said.
Arm pain?
Arm pain. Okay. Traditionally, you don't see them with the, crushing, crushing mid-chest substernal pain. You just don't get that from women. And a lot of the studies have shown that. There was a study done right here in Danbury that looked at the women coming through your ER who had had positive markers after AMI, and their symptoms were all over the place. Okay? None of them had crushing substernal chest pain. Okay? They were fatigued. They were nauseous. They thought they had the flu. They were a little more tired than reason. Okay? They just don't. They were sweaty. They thought they were in menopause. They were, okay? Because women tend to power through things.
You just said that.
Did you? Yeah, they do. That's exactly right. They tend to power through things. So then, what's the subsequent thing that happens from that? If women don't pay attention to their symptoms, the mortality rate the mortality rate for women is significantly higher than the mortality rate for men. Because women don't come in, women don't get the rapid treatment, women don't get treated appropriately. Okay? Because we don't pay attention to our symptoms. Okay? So, leaving today, each one of you needs to educate at least one woman about symptoms of AMI, okay? At least one. And do your part. Okay. Okay, emergency department admitted patient C to the percussive care unit with hypertension and possible ACS. Serial biomarkers remained essentially unchanged from the initial levels. One last thing. What do you think about her biomarker in the first paragraph? What might it indicate to you? It said the troponin 1 returned, indicating the level to be borderline. It might be that she had damage already. Okay, because it was borderline. It might be an evolving MI. It might be an old MI. It might be an evolving one. It might be on its way down. She may have had one previously. And we don't know because we don't have enough information. But there was certainly something that had happened to her heart, right? Okay. Okay. ED department physician at least listened to her and admitted her to the progressive care unit with hypertension because it was 210 over 120 and possible ACS. Serial biomarkers remained essentially unchanged from the initial levels. Repeat 12 lead 8 hours admission showed no indication of acute ischemia or infarct. Patient C had several episodes of epigastric discomfort and chest discomfort following her transfer to progressive care unit. She developed nausea and emesis with one episode. Sublingual nitroglycerin was effective in relieving her discomfort. Oral medications to lower blood pressure were effective, and subsequent measure indicated a blood pressure of 150 over 88. When asked, the patient denied any history of previous MI. When asked if a physician had ever instructed her to take lipid lower medication, she replied she, quote, couldn't afford it. The physician ordered a fasting lipid level to evaluate for dyslipidemia and an exercise stress test. During the stress test, patient C developed chest pain, diaphoresis, nausea before reaching the target heart rate. She underwent a follow-up cardiac catheterization and placement of a bare metal stent in her right coronary artery. Was this the appropriate way to manage this patient, and why? I see people nodding their heads and shaking their heads and looking disgusted. What do you think?
They kind of just waited.
They kind of just waited? What do you think?
What is the major delay? Because I think, isn't that part, I think, I have to look at our boards, but it's part of our pathway. The minute somebody has any of these symptoms, you want to do a lipid profile, you want to make sure that they're on a lipid lowering med. So it seems like that should have all been done.
When we got the cath before the stress test, I mean, she's got all these symptoms.
It was an interesting way to manage it, wasn't it? I mean, it wasn't necessarily awful because she was stable and they got her down, and it was a way to manage it. But given her symptoms, what do you guys think?
Well, the EKG didn't show any signs of ischemia, so I think it was appropriate to, admit her to the progressive care for close monitoring. And I don't know what the time frame should have been, like Deanna was saying, with giving the medications, if that should have been given first. But, I think doing the stress test and that's where they saw the ischemia, and then they placed the cath, or did the cath and then placed the stent. I mean, I think is that not appropriate? That sounds appropriate. But
It seems in this, the other group had the same questions, and that was, why would you do the stress test before the
is it because the
Yeah.
initial EKG didn't show the ischemia, so it's only when she is exerting herself? Because sometimes the initial troponin is a little bit elevated, like you were questioning before, and they call that stress ischemia. They say that all the time. So, but it's very common.
Yes, you will see that they say this is stress ischemia.
Right.
Yeah.
So if it's sometimes a little bit elevated, the doctors don't always get too
Crazy about it.
right.
It's just what you're looking for.
Exactly.
Yeah.
But I guess if they have clear indications, like the stress test, that they definitely do have some ischemia in the heart, that would make it okay to go forth with cardiac cath and the stent.
This actually, we may not like it because we think this poor little old lady was, not treated well. But this actually does go along with what American Heart Association protocols say. Yeah. I thought she should have been treated a little bit, more rapidly and better too. But actually, and you're exactly right, because it wasn't a clear picture yet, doing a stress test and not just taking her to what's considered an invasive testing first, not just popping her in and doing an invasive testing, is considered appropriate protocol. I didn't like it. I was ready to take her right in, and ready to pop her in. And, why did they make this little 63-year-old who had initial blood pressure of 210, run on the treadmill?
And someone who's non-compliant.
Yeah, I didn't get it either, but according to guidelines, it was an appropriate way to treat her. I didn't like it myself, but, okay.
What's the pathologic Q wave?
It means that the Q wave was not looking like a regular Q wave. It was either inverted or it was not, how you P, Q, I don't have any EKGs up there. It means that it was either widened or shortened.
But is that indicative of something wrong, or by calling it pathologic, is it?
It means that, pathologic means that it's not normal. That's just their term. Just say that, bud. We're a friendly crowd.
It was her question.
No, I was just saying, what's a Q wave? We would say like a QRS or
The Q wave is just the
It's just
first
the-
part of it.
okay.
Yeah,
just that one.
yeah, just that one little first part. Okay. So post PCI, she showed a markedly elevated BNP on day 3. She also developed dyspnea on exertion, unsteadiness on ambulation. Bilateral ankles evidenced 2+ edema and auscultation. Rails were heard in bilateral bases of the lungs. She again experienced epigastric discomfort. What does it indicate? What are your concerns? What actions might you take?
Congestive heart failure.
Some type of congestive heart failure. What else? A poor outcome. What about the BNP specifically?
Left ventricular dysfunction.
A left ventricular dysfunction. And what are you going to do about this?
Diuretics.
She would probably need diuretics, absolutely. How are you going to manage this? If you're the one there, you got to manage this. You're the feet's on the grounds.
You have a scale at home.
Now, she's still with you.
Okay.
She's still with you. This is a critical period. She's with you on day 3. How are we going to manage this?
So respiratory status.
Okay, we gotta evaluate a respiratory status, absolutely right.
Output, urine output,
Okay, so you're evaluating her respiratory status. What are we going to do to evaluate her respiratory status? Listen to her lungs. Okay, we're gonna check her stats, put her on some oxygen if she needs it. Okay. What else are we gonna do? Because we've checked her O2. Okay, pulse ox is 88. No, she doesn't have COPD. No COPD. So she's 88 with a pulse ox and she's got the rails. So what are you gonna do then?
chest x-ray.
Probably needs a chest x-ray. Okay, so she probably needs a chest x-ray. So what else
They'll
do
do
you
an
do?
echo if the doctor orders it, after you do all the other things that you're mentioning.
So you're gonna call your colleague and you're gonna say,
I need a fast.
Adjusted, they have another staff.
so you're gonna convey, you're gonna go boom, 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 right? This is what I have, so what we're getting to is, okay, I have this is what I've done this, this. We'd like you to do this, and this. What do you think, right? So that we have a very organized presentation, we have a very organized, okay, I saw this is what I have done. What do you think about doing this, and this? Because remember, you're the one who's there, you're the one who's seeing this patient. This is what I have done now. How about you doing this now? Because we're a team together working for this patient. Okay? And that's where we are, because you're the one who's there. Okay?
Wouldn't you be concerned about the recurrence of epigastric discomfort?
Yes, I would. So what would I do?
Maybe do PEKG, because couldn't that
I
be-
absolutely would do that. Yes. I would, that's absolutely a great pickup. I would absolutely do that. So when I called my colleague, I would say, and she has some more epigastric discomfort. So I have done an EKG and this is what the EKG shows. So maybe you might want to try your little darling self up here. Because we're a little concerned about this. Great pickup, yep. I would absolutely do that. And I maybe have given her a little something with the epigastric discomfort, because something else helped her with the epigastric discomfort before. I might have given her some nitro, yeah. Just as a little precaution.
You couldn't harm somebody by giving them nitro, right?
If her blood pressure is stable, no, as long as her blood pressure is stable and her heart rate is stable. We'll be fine. Yep. Okay. So now we got her through that, and you saved her because you did the chest x-ray, and you gave her a little nitro, she's fine, so. You did the EKG, and we're okay, so. And we gave her diuretics, and we fixed her, so she's fine, okay. All right, so now her fasting lipid level is 190, she has total cholesterol of 250, prescribed medications going out include simvastatin, metoprolol, hydrochlorothiazide, additional oral hypertensives, her, quote, usual oral hypoglycemics, aspirin, and clopidogrel. The discharge nurse begins planning for a return home. What are her priorities in planning for the discharge?
Medication, education.
Coupons.
No, compliance.
Compliance.
Maybe she needs coupons to afford her
Coupons would be
medication.
Okay, compliance is a big issue. And then, I said coupons, I thought you said coupons, but one of the things is that she stopped taking medications. And why did she stop? Because she couldn't afford stuff. So this is a patient that we really need to hook up with social services. because we can buffer up all we want. But if she goes out of here and stops taking medications because she can't afford them, we're gonna see her right back in here in 10 days. It's just not gonna work. Okay, so we can do our very, very best job, but it's not gonna help us. Okay?
And she's a diabetic, so then maybe educating her both because she's a woman and a diabetic about the difference in symptoms.
Mm-hmm.
Because diabetics don't usually feel the pain, right?
No. But both because of the neuropathy and because they get very different symptoms. Yes. Very, very important. And maybe hooking her into some groups. Okay. Exactly. All right. Got time for one last one?
Sure.
Okay, one last one. And this is a communication one. We have a male who's admitted to the progressive care unit following emergency treatment with PCI for acute myocardial infarction. He was driving to work with a coworker when he experienced chest pain and shortness of breath. His coworker drove him to the emergency room. He had an initial positive troponin level as well as a normal EKG. His EKG changes included T-wave inversion, elevation of ST segment, and formation of Q-wave. He was taken to the cardiac cath lab for an immediate PCI and a stent. Upon arriving to the unit, he has nitroglycerin infusion, oxygen, and continuous ECG monitoring. He continues to show T-wave inversion and elevation of ST segment. His vitals are temperature of 100, pulse of 68, respiration is 18, and blood pressure of 112/88. His wife arrives and asks to speak to the nurse. She says, "I can't believe he had to have a stent procedure done so quickly. He must have had a very bad heart attack." How would you respond using your knowledge of revascularization procedures, stents, and ECG and labs? How do you respond to this woman whose husband has come in and had a stent put in within 90 minutes? He hit the hospital and was stented within 90 minutes.
So he's gonna have a good outcome. Because we got him in a lot of time.
Should have less complications because he was treated so quickly, less damage to the heart. But also because his EKG and labs already showed changes, it probably has been going on for a little bit longer than maybe because you don't have immediate change in your labs.
Okay. Remember, she's coming in, she's scared to death. He's 48 years old, and all she knows is that he showed up in the hospital and they took him in immediately and put his stent in, and she thinks that's really quick to do. She doesn't understand anything about this. So how do you educate her that it's a good thing, that it's done quickly? And you started out very well with explaining why it's a good thing. She needs to know why, she needs to know your spin of why it's a really good thing that it was done quickly. In 6th grade language. She really does. So tell me, I want to hear it from you in 6th grade language in a very positive spin to this woman, how this is going to help her husband and how he's going to be good, why it was great that we got him here. So tell me.
I would say it was a good thing he was with his coworker who noticed the symptoms and immediately brought him to the hospital. And then I would list the diagnostics.
But tell me, don't tell me what you're gonna tell me, tell
Good
me.
thing he got here as soon as he did, because in the emergency room, we were able to do the EKG that showed that he was having a heart attack. And we were able to do whatever else, we did blood work and put him on the oxygen. And then, because of the results of those things, we have a protocol that says if he meets this level of care that he requires, he needs to have this done within 90 minutes. And that was our goal, and that's what happened this time. So it's not that it was a really bad heart attack versus a moderate heart attack. It was, he had a heart attack and he needed intervention within an hour and a half. And that's
But why did he need it within an hour and a half? I don't understand.
Time is muscle.
Because he had that intervention within an hour and a half, he will have a better chance of recovery and decreased risk of death related to
He's gonna die?
related to this incident. Yes, we're all gonna die.
He's only 48 years old. How could that happen? Why did they have to do it so quickly? I couldn't even get here and say anything to him before I came in.
His heart wasn't getting
What do you want
the
the answer for?
oxygen.
I don't understand why they had to do it so quickly.
It's evidence-based practice. Which means that here at the hospital, we follow what research suggests is the best way to, I'm stumbling over my own tongue now.
No, you're doing great. You're really doing great. That was a really good way to say it. Go ahead, keep going.
So the best way to treat these types of attacks.
Okay. What you did is you said we follow the research about the best way to treat these attacks. And the best way to treat them is to treat them fast. You just have to bring it down a little bit in your language. So we follow the research about the best way to treat them, and the best way to treat them is fast, so that, and brings in what you said, so that the heart muscle is protected and can get better quickly. You just have to bring it down in language. But I like how you said that the research says that this is the best way to do it.
And then I would probably throw in some things about she shouldn't expect to have that crushing pain, crushing pressure if she ever has a heart attack.
There you go. Okay, so that's only one person to treat it. But that's, you know, she's panicked because she's feeling I didn't get to go in and talk to him. You know. But when somebody asks, the research says that the quicker we can treat it, the more heart muscle we save. And the research says if we get to them within 90 minutes, the patients have the best chance of getting well and getting their heart muscle healthy. You put it in the positive, and put it in little tiny words. Okay? Because she's going to be hysterical. Okay, so now you tell me.
Okay. I would say.
My husband came in and they did it really quickly, and I don't understand why they had to do it so fast. I didn't get to talk to him beforehand. Why?
You said that. I would just say that.
No, just tell me.
Okay. Your husband came in with some chest pain, and we were able to see that he was having a heart attack, but because of our quick intervention, we were able to save his heart and save his life essentially, and hopefully he won't have as much damage as he would have if he hadn't come in so quickly, and he did the right thing. And he came in within a decent amount of time, and he's safe, and we took care of him, and and he's going to be okay. So just go wait out there in the waiting room. And as soon as he comes out, I'm going to come and get you, and the doctor's going to talk to you.
Okay, tell me.
So research says that this is the best way to treat this is fast. So what we did was treat him fast so that we could save his heart muscle. And he's doing well now, and hopefully he will not have a lot of damage to his heart as an outcome.
Okay. All right, tell me, why do you have to go so quickly?
Please, just wait for the doctor.
No, I want to talk to you. I like nurses better than doctors. Doctors talk up here, I want to talk to a nurse. My sister was a nurse. My sister's a nurse, and she said to talk to the nurses. The nurses will tell you what's happening.
So your husband was having some chest pain and he got here quickly and we were able to intervene very quickly, and research shows that this is how you're going to save the most amount of heart muscle, and he's going to be okay because he came in and we treated it.
All right. Very good, short, to the point, good, okay? But do you understand what I'm saying? You have to, you want to go, tell her why it was done fast. Okay. All right, I'm not going to torture you. Good. Do you have questions about this stuff that you want to ask me? No? Okay. Thank you.
Thank you.
Thank
you.
All righty. Stand up and wiggle around. I think they have something else planned for you. So you're all set for stuff?
Yes.
Yeah.
Next week.
Next week we start up again. Yeah.